Hello. So in this section, I will talk about anesthetic management of intracerebral aneurysmal clipping. The cerebral aneurysm is a challenging condition, and when it bleeds, it is associated with a lot of complication. Definitive management is surgical clipping or coiling. In this section, I would talk a little bit about the aneurysm. I would talk about how do we do the initial stabilization in the patient coming to the ICU with a subarachnoid hemorrhage due to cerebral aneurysm. We would talk about different grading system which grades the subarachnoid hemorrhage caused by cerebral aneurysm, and the grading system which grades the associated risk associated with subarachnoid hemorrhage caused by cerebral aneurysm. We would talk about all the complications which are associated with cerebral aneurysm, like your vasospasm, your rebleed, your seizure, cardiac complication, respiratory complications. How do we manage them and stabilize our patient? Then we would talk about the perioperative management, the pre-anesthetic evaluation. What are the important points that we need to specially consider in these patients? What are the important precautions we need to take in intra-op period? It's the special monitoring which is required in these patients. Then what are the important intra-op complications like cerebral aneurysm, rupture which can happen intra-op during the aneurysmal dissection and clipping. All these kind of complications which we can face in intra-op period, we would discuss about it, and we would also discuss how do we dispose this patient in post-op period. So let us start our discussion with the definition of cerebral aneurysm. So what do we mean by cerebral aneurysm? Cerebral aneurysm is due to the weakness in the cerebral vessel, whether it is artery or vein. Because of the weakness, they dilate where they are weak into any, let's say, shape like more saccular shape or fusiform shape. So basically, cerebral aneurysm is a cerebrovascular disorder in which weakness in the wall of cerebral artery or vein causes localized ballooning or dilatation of the vessel. This vessel, where it gets ballooned, they are very weak and very prone to rupture, right? What is the incidence of cerebral aneurysm? The incidence in adult is between 1 to 5%, and the ruptured cerebral aneurysm, they encompasses 75 to 80% of non-traumatic subarachnoid hemorrhage. So they are the cause of 75 to 80% of non-traumatic subarachnoid hemorrhage. So 75 to 80% spontaneous subarachnoid hemorrhage is because of the ruptured intracranial aneurysm, which is highest in the non-traumatic causes of subarachnoid hemorrhage. Then 1 in 10,000 per 10,000 person, the incidence of ruptured aneurysm is there. And when the aneurysm rupture, the mortality is 50%, right? And the 50% who survives, the patient who survives, in only 60% of those patients, the patient return to the full functional independence without a neurological deficit. So you can see, with a pretty high incidence, the outcome is little poor. So when a patient with ruptured cerebral aneurysm comes to critical care unit, for critical care management, what is initially required is the stabilization of the patient and reversing the life-threatening conditions. So initial thing is we need to stabilize the patient. So when the patient presents to the for critical care management, what we need to do is reverse and stabilize the life-threatening condition. So our goal is to reverse and stabilize life-threatening condition. So we need to take care of the patient's ABC as we do for any emergency patient. So we need to take care of the airway and breathing of the patient, and definitely we need to take care of the cardiovascular system, that is circulation of the patient. Now a lot of patients, they with ruptured cerebral aneurysm presents with seizure. We need to stabilize the seizure of the patient. So we need to just stabilize the life-threatening condition. Number of these patients may require immediate intubation. The reason being a poor GCS, hemodynamic imbalance, respiratory compromise, right? Hemodynamic imbalance, respiratory compromise, and definitely intractable seizure can be the causes requiring immediate intubation. So Immediate intubation may be required in patient with poor GCS of less than equal to 8, patient with raised intracranial pressure, patient with poor oxygenation, patient with hemodynamic imbalances, and those patients who require heavy sedation or paralysis to manage them. So in all these conditions, we would like patient should be intubated. Okay. So how do we classify patient who comes with ruptured cerebral aneurysm? That is, how do we classify the subarachnoid hemorrhage caused by the cerebral aneurysm? There are two most important classification based on the patient's clinical condition. One is Hunt and Hess, other is the classification done by World Federation of Neurosurgeon. Both the classification I would discuss, and I would also tell you the mortality associated with the different, let's say, grades of these classifications. So let us first discuss Hunt and Hess classification. So Hunt and Hess classification for the grading of subarachnoid hemorrhage caused by cerebral aneurysm, it was given in 1968, and the Hunt and Hess graded the patient in 5 categories, grade 1 to grade 5. Later on in 1974, Hunt and Koshnik, they modified the classification, added grade 0 for unruptured aneurysm. So this was added later on, grade 0 for unruptured aneurysm. Okay. And grade 1, they divided grade into grade 1A with no acute meningeal reaction but fixed neuro deficit. And previously in grade 1, it was only minimal headache with normal neurological examination. So only the meningeal irritation was taken in consideration with normal neurological examination. So grade 1A was added. The patient has no meningeal irritation but a fixed neuro deficit. Okay, and mortality is 2 to 5% in grade 1. Grade 2, moderate to severe headache, knuckle rigidity, no neurological deficit other than cranial nerve palsy. 5 to 10% mortality. Grade 3, now the consciousness starts decreasing. Lethargy, confusion and mild focal deficit. 5 to 10% mortality. Grade 4, stupor, moderate to severe hemiparesis, possible early decerebrate rigidity and vegetative disturbances. Now this is associated with high mortality, 20 to 30%. And grade 5, deep coma, decerebrate rigidity, moribund appearance. 30 to 40% is the mortality rate. So this was given by Hunt and Hess. And in the same modification in which grade 0 and grade 1A was added, they added one grade for any associated complication, comorbidity like hypertension, diabetes, COPD, severe atherosclerosis, angiographic vasospasm, right, in these patients. So this is Hunt and Hess classification. The next very important classification is classification given by the World Federation of Neurosurgeon, WFNS classification. So WFNS classification of subarachnoid hemorrhage grading, right? They again graded in 5 grades, 1, 2, 3, 4, 5, based on 2 important parameters, the GCS score of the patient and motor deficit present in the patient. So grade 1, GCS 15, there was no motor deficit. Grade 2, GCS 13 to 14, no motor deficit. Grade 3, GCS 13 to 14 with motor deficit. Grade 4, 7 to 12 GCS and motor deficit present or absent. In grade 5, 3 to 6 GCS present or absent motor deficit. You can see in grade 4 and 5, when the patient starts having poor GCS, outcome in these patients starts becoming worse and worse compared to the patient with a good GCS. Okay, so this is WFNS classification of subarachnoid hemorrhage, right? Now, another classification which is very popularly used is modified Fisher classification. Now, this classification is based on the CT appearance of the subarachnoid hemorrhage caused by the intracerebral aneurysm. So, this is a CT grading, right? CT grading. So, modified Fisher scoring. Now, this is based on CT defined hemorrhage pattern. CT defined hemorrhage pattern, right? And this also tell us about the risk of delayed cerebral ischemia associated. So delayed cerebral ischemia associated. So modified Fisher grade 0, no subarachnoid hemorrhage or intraventricular hemorrhage. Now the risk of delayed cerebral ischemia is 0%. Modified Fisher score 2, minimal or thin subarachnoid hemorrhage but no intraventricular hemorrhage seen. The risk is 5% of delayed cerebral ischemia. Now grade 2, minimal subarachnoid hemorrhage with intraventricular hemorrhage in both lateral ventricle. 15% risk of delayed cerebral ischemia. The modified Fisher score 3, dense subarachnoid hemorrhage, and modified Fisher grade 4, that is dense subarachnoid hemorrhage with IVH in both ventricle. Both are associated with 35 and 34% risk of delayed cerebral ischemia. So this is telling us about the risk of cerebral ischemia associated with the subarachnoid hemorrhage caused by intracerebral hemorrhage, intracerebral aneurysm. Now there is another classification which incorporates the modified Fisher classification and World Federation of Neurosurgeon classification to again predict the risk of delayed cerebral ischemia in the patient. They have graded the patient in 3 colors, that is green, yellow and red. So we have something called vasograde system. Vasograde system. Now vasograde system, this has been developed to predict the risk of delayed cerebral ischemia following subarachnoid hemorrhage. It is based on the World Federation of Neurosurgeon scale and modified Fisher scale at the time of admission when the patient is admitted. Now 3 colors has been given, the green, yellow and red. Green color is for those patients who have WFNS score 1 or 2 and modified Fisher score 1 or 2. Yellow for WFNS score 1 between 1 to 3 and modified Fisher 3 and 4. Now both of these have equal risk of delayed cerebral ischemia. It was seen, but the red one, that is WFNS score of grade N4 or 5 and any modified Fisher scale scoring, they have been associated with the highest risk of delayed cerebral ischemia. So this red one, highest risk of delayed cerebral ischemia. So patients who were coded red, they were more intensely monitored to prevent the risk of the cerebral ischemia which would have developed in them later on. Okay, so they are the highest risk for delayed cerebral ischemia. Then one more very important grading system given by your Ogilvy and your Carter. Now this grading system is based on age, based on the Hunt and Hess classification, based on modified Fisher classification, and based on the type of the aneurysm, the size of the aneurysm. A point system grading has been done. Now this the Ogilvy and Carter classification, in this the patient is given points and the point varies from 0 to 5, and this is very nicely predicting the patient's outcome. So this predicts outcome of the patient and accurately substratifies the patient for treatment. Accurately stratifies patient for therapy, right? So this is basically therapy guiding scale, right? So in this, as I told you, the grading was given on the basis of age, on the basis of Hunt and Hess classification, on the basis of your modified Fisher and the type of aneurysm and the size of the aneurysm. So age less than 50 or 50, age less than 50 years, right? 50 or less than 50, score 0 was given. Above 50, score 1 was given. Then Hunt and Hess grade 0 to 3, that is where no coma is associated, 0.0 was given. Hunt and Hess grade 4 to 5, 0.1 was given. Fisher scale 0 to 2, 0.0, 3 to 4, 0.1. Aneurysm size 10 mm or less, 0.0, greater than 10 mm, 0.1. And giant posterior circulation aneurysm, of size 25 mm was independently given 1 point, right? So if you count the total score, it comes out to be 1, 2, 3, 4, 5. So total score is 5, the highest score is 5 and the minimum is 0. Patient with low score 0 to 2, they have a better outcome compared to the patient who has a higher score between 4 to 5. Okay, so patient with 0 to 2 has definitely better outcome compared to patient with 4 and 5. They have the worst outcome and highest mortality. Okay, so this is your Ogilvy and the Carter grading system, point system, right? So these are the different risks, different grading system for ruptured cerebral aneurysm, and they also tell us, they also predict the risk of associated complications like vasospasm and delayed cerebral ischemia, and also predict the outcome in these patients. This classification is very important to be done in the patient admitted immediately with ruptured cerebral aneurysm. Okay, now let us talk how do the patient presents. So let us little bit talk about the diagnosis of the cerebral aneurysm. So how do the patient present? They present the cerebral aneurysm, the patient presents with headache. They always, the history of, we take the history of the presenting illness, patient will always complain of headache, may or may not be associated with nausea and vomiting, right? And they may present with, they may give a history of seizure, which is seen in 6 to 16% of these patients, and acute confusional states. Acute confusional state, right? Acute confusional state. And loss of consciousness and loss of consciousness. Okay. So this is what we will get in the history of presenting illness. The patient would tell us that patient had headache from few days associated with nausea and vomiting, and loss of consciousness was associated, acute confusional state, and maybe associated with seizure also, right? If we take the past history, patient will complain of sentinel headache. Sentinel means very severe sudden headache, right? So patient will complain of this term sentinel headache. Sentinel headache is the term used for the headache caused by subarachnoid hemorrhage, sudden and severe, sudden and severe, sudden and severe. Now, if we take the familial history, now association of the cerebral aneurysm in families would be very high, 5 to 20%. So 5 to 20% predisposition of cerebral aneurysm if it is present in family. Now first degree relative, if first, let's say, degree relative have the history of cerebral aneurysm, the risk of aneurysm increases 7 times. Okay, so there is 7 times more chances of a patient having cerebral aneurysm if the first degree relative have the cerebral aneurysm. Okay, then associated disorders. What are the associated disorders which we will see in these patients? So we will see hypertension. There are some associated Ehlers-Danlos disease, etc., associated with the patient. So associated would be your hypertension, endocarditis, polycystic kidney disease, your Ehlers-Danlos syndrome, Ehlers-Danlos syndrome, your neurofibromatosis type 1 is associated with aneurysm, and Marfan's syndrome. Marfan's syndrome. So we need to even rule out the absence or presence of these syndromes, because when a patient is syndromic, they may be associated with other complications as well. Okay, then we should always take the personal history of the patient, history of the alcohol or smoking or illicit drug abuse. So we need to take the history of smoking, alcohol, and illicit drug abuse. So these history should be taken. When we do physical examination of these patients, there would be signs and some signs of meningeal irritation. So in physical examination, there would be meningeal irritation seen in 75% of the patient. So what would be the signs of meningeal irritation? When we do the physical examination, there would be neck stiffness, there would be possibility of positive Kernicks and Burzynski sign. So there would be meningeal irritation, so neck stiffness, low back pain, then bilateral leg pain, and possibility of positive Kernicks and Burzynski sign. Burzynski sign, right? So positive Kernicks and Burzynski sign could be there, right? So in Kernicks sign, when you flex the hip and the knee joint of the patient, right? The patient complains of pain at the 90-degree when you flex it. So you need to see whether the meningeal irritation is present or not by seeing all these features. Then you should always examine the pupil of the patient. Depending upon where is the aneurysm placed, there would be different pupillary sign. So when we examine the pupils, there is a possibility of monoocular blindness. This monoocular blindness would be there in large anterior communicating artery aneurysm. So if there is a large ACOM or there is an ophthalmic aneurysm, ophthalmic aneurysm, okay? Ophthalmic aneurysm, okay? Then oculomotor palsy. In this fixed pupil, we can get fixed dilated pupil, ptosis and ophthalmoplegia. Right? We will get an oculomotor palsy. And this is more commonly seen in the posterior communicating artery aneurysm, PCOM, basilar tip aneurysm, and superior cerebellar artery aneurysm, right? Apart from this, patient will with raised intracranial pressure would show the abducen nerve palsy. So abducen palsy with raised intracranial pressure. Now there is a possibility of motor deficit also seen in these patients. Motor deficit. So in classification also we saw the motor deficit. Hemiparesis in the opposite side. Hemiparesis in contralateral side of rupture. And middle cerebral artery, aneurysm rupturing into Sylvian fissure. Middle cerebral artery aneurysm rupturing into Sylvian fissure. So the motor deficit would be more common. So patient will present with motor deficit as well. Okay. So these are the things which we will get in the examination of the patient, in pupils, in motor deficit, and your signs of meningeal irritation. Okay. Now, what are the complications or what are the important investigations before complications which we need to get done in these patients for confirmation? Now, CT scan, this is the first line of investigation. False negative is only 2%, the association of false negative is only 2%, and first 12 hours after subarachnoid hemorrhage, there is 98 to 100% sensitivity that it will detect the subarachnoid hemorrhage. That is your non-contrast NCCT. So whenever the patient comes, we always get an NCCT done. Okay. Now this number, this sensitivity drops to 93% as the time passes, 24 hours after subarachnoid hemorrhage, and after 6 days further less chances of diagnosis by NCCT, 57 to 85%. So when we take the history, we should always take the history in a way that we would know that when was the first symptom which came to the patient. Maybe patient come to us a little late after the presenting complaint. So depending upon that, there is a chance of the false negative in NCCT. Okay, so keep it in mind. It is most sensitive in first 24 hours and its sensitivity decreases. So it is first 12 hours highest sensitivity. So in first 12 hours, 98 to 100% sensitivity. In 24 hours, it decreases to 93%. And with 6 days of the onset, the sensitivity further decreases to 57 to 85%. Okay, so we would need some other investigation if patient presents in a delayed way. So this is how it will present in the CT number. This is the star sign. We can see that your bleed in the cisternae, right? Blood in the cisternae. So this star sign. So we can see the blood in basal cisternae. Okay. So this is star sign, which we can see in the CT. Okay, lumbar puncture. Now lumbar puncture is another investigation which we can do. But when we do lumbar puncture, rule out the raised ICT. So always rule out the signs of raised intracranial pressure. So xanthochromia, 6 hours to 3 weeks. Xanthochromia will be there and it will be there for from 6 hours to 3 weeks. Most useful when patient presents with more than 1 week and NCCT is negative, NCCT is normal. Okay, so we are suspecting the chances of the subarachnoid hemorrhage is there in this patient. NCCT is normal and patient has presented little late to us. Now, what are the other causes of xanthochromia seen in lumbar puncture? Now, brain tumors, infection, severe systemic jaundice, hypoproteinemia, and traumatic tap. The traumatic tap is pretty common, and in this we can differentiate it from the xanthochromia by your traumatic tap, the change in color. We can differentiate it from xanthochromia by spectrophotometry. So remember, traumatic tap, it will be pink or orange discoloration due to oxyhemoglobin, and it can be differentiated from xanthochromia by spectrophotometry. The other investigations like cerebral angiography, digital cerebral angiography, this is gold standard. Cerebral angiography is gold standard. Okay, a 3D reconstruction is used for detecting and the planning treatment. So where is the aneurysm? How we need to plan the treatment, what is the depth of the where the aneurysm is located, everything we get a 3D reconstruction. Now cerebrovascular anatomy, aneurysm location, source of bleeding, aneurysm size, shape, orientation of dome, neck, relation to the parent and the perforating artery, and association of vasospasm. Each and every information we will get by cerebral angiography. That's why it is called gold standard. But the problem is it is an invasive investigation with its potential complications like anaphylaxis and all, and it is pretty expensive. So two issues, expensive and invasive investigation. What is the other investigation which we can do, which is pretty less expensive and also gives a good let's say sensitivity in detecting? One is your simple CT angiography. Now CT angiography is non-invasive, requires a short scan time and high diagnostic accuracy. So it also has a high diagnostic accuracy. So if not possible for cerebral angiography to be done, CT angiography also give us diagnostic accuracy high. But when we are planning the treatment, right, then definitely cerebral angiography would be of better help. And when we cannot get cerebral angiography and the CT angiography in both, which we require dyes to be given, then we get done MRA, that is magnetic, right? The MRA scan we can get done, right? So in MRA scan, we have two type of let's say MRA scans which can be done: time of flight scan, two acquisition techniques, and phase contrast. Both have different sensitivity and specificity. So in comparison to the gold standard, right, DSA, that is your cerebral angiography. In comparison to cerebral angiography, your MRA with time of flight is 86% to 84% sensitive and specific. So compared to DSA, the TOF MRA is 86% sensitive and 84% specific. And sensitivity and specificity of contrast enhanced MRA is 86 and 89%. Okay. Used in NCCT negative cases in patient with renal failure and contraindication to giving contrast in these to patient whom we cannot give contrast. So in the patient whom we cannot give contrast or who are renal dysfunction patient and who are negative NCCT, MRA would be very useful. So important role in follow-up of embolized cerebral aneurysm after endovascular treatment. So it is also very good tool in follow-up, right? So this MRA scan has specific indication. So these are the different imaging which we do. Immediately when the patient comes, NCCT is done. Immediate presentation, NCCT has high sensitivity, but delayed presentation, NCCT has a poor sensitivity. Okay. Then we need the cerebral angiography before planning the treatment, and in special circumstances where cerebral angiography cannot be done, then your MRA scan can also be done in the patient. Okay.